Jayeeta BOSE.
Good afternoon. I'll be presenting a case series of microbial keratitis following collagen cross-linkage. So as we all know, CXL or collagen cross-linkage is an FDA-approved therapy to stiffen the cornea and prevent progression of corneal ectasia in patients of keratoconus, which uses riboflavin and UVA rays to increase the mechanical rigidity of the corneal stroma and halt or delay keratoconus. It can be of three types: standard, accelerated, or transepithelial, and I think most of us are doing the accelerated protocol these days. And also the prevalence of keratoconus in our OPD setting has been increasing, and a study which has been conducted in rural population has been shown to report the prevalence of almost 2.3% of keratoconus. The incidence of infectious keratitis after CXL can vary, and it can be as low as 0.0017% to as high as 2.4%. So in this case series, we retrospectively want to report a series of 2 patients who presented with microbial keratitis following accelerated CXL in a multispecialty eye hospital in the same week. We attempted to determine the causative organism, risk factors, if any, and the response to treatment. The first case was an 18-year-old male, and he is a known patient of congenital fibrosis of extraocular muscles. He also has keratoconus, and he underwent accelerated CXL in left eye. His BCL was removed after 3 days, and 3 days after BCL removal, he presented with this picture, and corneal scrapings revealed Staph aureus. And then we did the culture sensitivity also, and he was treated with fortified cefazolin, fortified tobramycin, chloramphenicol, oral doxycycline. And after 1 week, when there were signs of resolution and scarring, we started him on loteprednol eye drops as well. He improved to 618 after 4 weeks. So we see here that the corneal scrapings has shown resistance to many of the commonly used 4th generation fluoroquinolones like levofloxacin, moxifloxacin, and in fact the lesser used drops like chloramphenicol and tobramycin have been sensitive in this patient to the organism. In the second case, it's a 15-year-old male patient who is a known case of VKC since 5 years. He had bilateral accelerated CXL performed. In the first post-op day, his BCL had dropped off, which is quite common in keratoconus patients, and it was replaced in the OPD. And after 1 week, he presented with this complaints of pain, redness, watering, and diminution of vision. He, after corneal scrapings was done, and coagulase negative staphylococcus was grown on culture. And similar sensitivity was seen in this patient also. He was given fortified drops, chloramphenicol and oral doxycycline, along with loteprednol started after 1 week. In his sensitivity also, we see that he is resistant to many of the commonly used 4th generation fluoroquinolones. And this patient also resolved gradually over a period of 4 weeks with steroids. In the review of literature, the available data indicates that bacteria are the most common organisms in post-CXL keratitis. The most common time of presentation is about 4 to 7 days after surgeries. The use of steroids and bandage contact lenses in the immediate post-operative period were associated with infection. Atopies can worsen the course of the infectious keratitis. UVA could be a trigger to reactivate latent HSV infection. In our series, both were young males. Pre-existing risk factors were present in both cases. Both of them presented with acute onset of symptoms around 7 days. Staph was isolated in both on culture, and it was resistant to the 4th generation fluoroquinolones. And both these subjects responded well to fortified antibiotics along with steroids, and they scarred at 3 to 6 weeks. In conclusion, we should be aware that VKC, blepharitis, mebomitis, conjunctivitis, canaliculitis, all these conditions may predispose patients to post-C3R keratitis. We should use pre-operative and post-operative antibiotics. The CXL should be performed preferably in a OT with all sterile precautions. Alcohol debridement is advised because it can reduce the ocular microbial load. Judicious use of steroids and close monitoring till the epithelium has healed. Transepithelial may be safer as the epithelium is intact. Both eyes, simultaneous CXL, if possible, should be avoided. And microbiology guided treatment with early use of topical steroids may hasten the visual recovery. Some people see the scars and it is wounding, they remember. To me, they are a proof of the fact that there is healing. Thank you very much.
A very good presentation. And you had only any other local factors like this lid margins was all ruled out before the surgery?
Yes, ma'am. As such, there was no, the patient who had this CFOEM, he had some ocular motility problems, he had ptosis. And I think the one, BCL could have been one of the factors because these patients, difficult to retain the BCL in some of these eyes. And the hygiene in case of young boys, children not that concerned about hygiene.
Yeah. So what I mean is the pre-operative lid hygiene is also
Yes,
very
ma'am,
important.
right.
If that has been missed, and then we cannot be blaming. Of course, the patient will have epithelial defect. BCL falling is definitely triggers. And then you are trying to replace. You have shown that it was replaced.
Ma'am, it was replaced in the OPD. So that, so it was replaced in the OPD on the first post-operative day. But obviously, OPD may have some contamination if you are replacing a BCL in the OPD.
Right.
Thank you.